Welcome to Journal of Cardiac Failure's YouTube channel.
Heart function, not failure.
Heart success.
Mentorship.
And what matters.
We care.
We hope you enjoy the episode.
Hello, everyone. My name is Dr. Martha Gulati. I'm a preventive cardiologist at Cedars-Sinai Heart Institute, and I'm the Director of Cardiovascular Prevention, as well as the Associate Director for the Barbara Streisand Women's Heart Center in Los Angeles. I also serve as the Patient Empowerment Editor for the Journal of Cardiac Failure. And as part of that role, as well as in my daily practice, patient education is critically important to me. The advice we give our patients about lifestyle changes, including diet and exercise, has a major impact both on the quality of life measures, but as well as the patient's outcomes. But in caring for heart failure patients, I have noticed a surprising vacuum of literature surrounding fluid intake and fluid restrictions. Despite the fact that there's little concrete evidence to back up any particular recommendation, it has become common practice for cardiologists to recommend fluid restrictions to all heart failure patients. So today I want to talk about a design paper that's being published in the Journal of Cardiac Failure, the Fresh Up trial, and that might help answer some of these burning questions in this area. And I'm fortunate today to be able to discuss this with two bright young trainees, Dr. Aurelie Merlo, a cardiothoracic surgery resident at UNC Chapel Hill, and Dr. Kenechukwu Mezue, a clinical fellow at Yale. Aurelie, let's start with you. Why should we be interested in the Fresh Up study?
Hi, Dr. Gulati. Well, Kene and I are quite familiar with this study because we reviewed the design paper for JCF along with Dr. Drew Ambrosy from Kaiser-Permanente as a part of JCF's Reviewer Mentorship Program. As you mentioned, fluid restriction is so commonly recommended to heart failure patients, but there's little data to back it. In fact, there is emerging evidence that fluid restriction may be harmful. Professional cardiovascular societies do not make any strong recommendations in this space. Fresh Up will try to bridge this knowledge gap. It is an ongoing, open-label, randomized controlled trial that is presently enrolling patients at centers in the Netherlands.
So interesting. Well, Kenny, can you tell me a little bit about the design of the trial?
Sure. This trial plans to enroll 500 patients, and it will compare recommendation of liberal fluid intake with a recommendation of fluid restriction of about 1,500 milliliters per day in stable outpatients with chronic heart failure. The primary outcome will be a change in the Kansas City Cardiomyopathy Questionnaires overall summary score from baseline to 3 months. The secondary endpoints will include scores for thirst distress and a safety assessment measured by the composite of death, all-cause or unplanned heart failure hospitalizations, and worsening heart failure that requires an administration of IV loop diuretics.
So will they include patients with heart failure and preserved ejection fraction?
Yes. In fact, any ambulatory patient with heart failure can be included regardless of left ventricular ejection fraction, as long as patients are on stable heart failure guideline-directed medical therapy without any recent medication changes, procedures, or hospitalizations.
Well, that's great. It sounds like this trial may help answer a lot of our clinical questions.
Yes, that's the hope. Congestion drives many of the symptoms of heart failure and leads to ED visits and hospitalizations. While fluid restriction seems like a logical way to tackle congestion, recommendations to fluid restrict are based on intuition and not on hard data. Fluid restriction can be challenging to patients. Thirst distress is a real problem for heart failure patients, and fluid restriction is a constant reminder of their disease. It is possible that it could also lead to adverse outcomes. Prior to Fresh Up, very few randomized trials looked at fluid restriction, and they only had 75 patients enrolled. Fresh Up will change all this.
It certainly will, but do either of you have any reservations about this study?
Well, there are some obvious limitations inherent to the structure of a study like this. Open label design means that the nature of the intervention wherein actual fluid intake is not regulated can lead to issues regarding adherence. And all of this means that there's a risk of bias being introduced. But as Kene mentioned, this is a trial of stable heart failure patients. Patients with hyponatremia, reduced renal function, or who had recent changes in GDMT were purposefully excluded. In the real world, it is these very patients with diuretic resistance, hyponatremia, and advanced heart failure in whom fluid restriction is most commonly recommended, and in whom it is supposed to be effective. As such, a trial in stable heart failure patients may not give us the answers we are looking for.
Yes, and also looking at the endpoint, measures like the Kansas City Cardiomyopathy Questionnaire score and the Test Distress Questionnaire, while comprehensive and patient-oriented, are quite subjective and not always reproducible. And while there is an objective safety secondary endpoint that looks at death, hospitalization, and worsening heart failure, there are unlikely to be many safety events in this population. Yet Aurelie and I are optimistic. Data is much needed in this space, and this will be the first randomized controlled trial enrolling such a large number of patients. We are hopeful that the results will help heart failure cardiologists, and for that matter, all cardiologists, give evidence-based recommendations to their patients regarding fluid restrictions, in the same way that the recent sodium HF trial helped answer some questions about salt restriction.
What are your thoughts, Dr. Gulati? What have you been doing in your practice?
Yeah, we haven't had much guidance. And so I think in the meantime, while we're waiting for this excellent study to come out, I think what I've been doing in my practice is personalizing it for the patient in front of me. If somebody is very sensitive to fluid intake and we see that drives a lot of their hospitalization, that might be somebody that I'm more strict about fluid restrictions. But on the other hand, if somebody is not sensitive to fluid intake, I don't restrict them. And I think this is why we need this study, because we see so many patients getting different information when they are hospitalized. They're told no fluids, no salt intake, etc. So we've really got to do studies like this. So I'm really looking forward to the results of Fresh Up. In the meantime, check out its design paper. It's out now in the Journal of Cardiac Failure. And I'd like to thank Aurelie and Kene for not only reviewing this article, but also presenting it here with me today.